Hello everybody, this is Dr. Nadeem. This is Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. We also have a Telegram group for accessing all lecture related information. There's a Google Drive where the PDF of all lectures are available. These are the disclaimers. And this is phase 3, which is recorded pathology lectures. And today we have Pursue 15P, which is hematology erythrocytic disorders. And the topic of the day is disorder of hemoglobin structure, sickle cell anemia, and related abnormalities. And to speak on that, we have Dr. Gautam Gopal Bhagwat, who is an MBBS and MD, R.D.Gardi Medical College, Ujjain. He has done a PDF in lab hematology from Tata Medical Center, Kolkata. Presently, he is a consultant hematopathologist and assistant professor at R.D.Gardi Medical College, Ujjain. He has also worked as a section in charge in hematology and flowcytometry at Suraksha Diagnostics, Kolkata. He has had a hands-on training at the University of Salamanca, Spain, in flowcytometric analysis of various hematological malignancies and MRD. In 2019, he received the Berend Houwen Travel Award at the annual conference of the ISLH in Vancouver. His areas of interest is hemato-oncopathology and flowcytometry. So over to Dr. Gautam to start his lecture on disorders of hemoglobin structure, which is sickle cell anemia and related abnormalities.
Namaste and hello to everyone. I would like to thank Dr. Nadeem for giving me this opportunity once again. Earlier, I was a part in phase 1 where I had talked on the basics of flow cytometry in 3 lectures. Today, I am going to speak on a very interesting disease, that is sickle cell anemia. It is the first molecular disease and the first disease where point mutations was noticed around 70 to 75 years ago. Also, the molecular technique of RFLP was used in this disease for the very first time. Sickle cell anemia is common in central parts of India and the states such as Madhya Pradesh, Gujarat, Chhattisgarh, Orissa, Maharashtra, etc. Sickle cell anemia is an inherited disorder of globin chains that causes hemolysis and chronic organ damage. I'd like to introduce another term, that is sickle cell disease. Now, sickle cell disease refers to the group of hemoglobinopathies that include mutations in the gene encoding the beta subunit of hemoglobin. The subgroups involved in sickle cell disease are sickle cell anemia, hemoglobin sickle cell disease, hemoglobin sickle beta thalassemia, that is double heterozygous, and sickle cell trait, that is a heterozygous mutation and rarely presents with any clinical signs or symptoms. It is also called as sickle cell trait. Sickle cell anemia is the most common form of sickle cell disease with a lifelong affliction of hemolytic anemia requiring blood transfusions, pain crisis and organ damage. So here I would like to emphasize once again, sickle cell anemia is the disease, while sickle cell disease encompasses all the 4 or 5 forms in which you have a HBS gene. Now, we all know why this disease is called as sickle cell anemia. It is because of this presence of these cells which are also called as holly leaf cells or are the crescent cells which are pointed at both the ends. I'll start with the hemoglobin structure. Hemoglobin structure is a tetramer of 4 monomers. That is, heme plus globin forms 1 monomer, and in this way 4 monomers are present. Adult hemoglobin is 2 alpha and 2 beta chains. Each chain is a globin chain and it is a quaternary structure of polypeptides. The alpha chains are 141 amino acids and the gene is encoded at chromosome 16, while the beta chain comprises of 146 amino acids. The gene are present on chromosome 11. Now, beta-like chains are also epsilon, gamma and delta. Heme, as you all know, comprises of protoporphyrin and iron. So, in the post-embryonic stage, what all hemoglobins do we see? HbA, it is the normal adult hemoglobin. Now, in post-embryonic stage, all the hemoglobins would have one alpha chain and two alpha chains and two beta chains or beta-like chains. So, HbA is the normal adult hemoglobin. When two beta chain comes and attaches to 2 alpha chains. So 2 alpha, 2 beta is normal adult hemoglobin. Now the other beta-like chain is delta chain. When this beta chain is replaced by delta chain, or we can say that there are 2 alpha and 2 delta chains, it is HbA2, which is also a normal adult hemoglobin but is present in very less amounts. Now another beta-like chain is gamma chain. In place of 2 beta or 2 delta, if we have 2 gamma chains, that is 2 alpha and 2 gamma chains, then it is the fetal hemoglobin which is present in the embryonic stage, also in the later stages of embryonic stage, and is present up to 4 to 6 months of age. Well, I hope all of you remember the etiological classification of anemia. I'll just review it through. So etiological classification of anemia, there are three main important subheads. Anemia due to blood loss, anemia due to impaired red cell production. Impaired red cell production anemias are the most common anemias, that is the iron deficiency anemia or the megaloblastic anemia, aplastic anemia, etc. And third is the anemia due to excessive red cell destruction, which is also called as hemolytic anemia. I'll emphasize on this because sickle cell comes under this group. There are two major subgroups. One is intravascular hemolysis due to abnormalities extrinsic to red cells. Now there is some wordplay over here, so I would like you to concentrate. Intravascular hemolysis, that is the red cells are getting destroyed in the vessels, but it is due to abnormalities extrinsic to red cell. That is, the abnormality is not present in the red cell itself, but it is present outside the red cell, the most common being the autoimmune hemolytic anemia. The other one is extravascular hemolysis due to abnormalities intrinsic to red cells. Now again, abnormalities are intrinsic to red cell, that is present within the red cells, but the hemolysis is extravascular. Extravascular hemolysis due to abnormalities intrinsic to red cells. Extravascular hemolysis, that is in the spleen, most common site. Now what abnormalities can be present in the red cell? So the abnormalities may be related to hemoglobin, may be related to cell membrane, or may be related to enzyme. Cell membrane abnormalities are seen in hereditary spherocytosis or hereditary leptocytosis, while enzymes G6PD or pyruvate kinase are enzymes which causes the deficiency of which causes hemolytic anemia. Again, we'll concentrate on disorders of hemoglobin because sickle cell anemia is a disorder of hemoglobin. Disorders of hemoglobin are almost always inherited and the most common genetic disorder in this world. These may be quantitative, which are the thalassemia syndromes. That is, the chains, alpha chain and beta chain, are either absent or are produced in lesser quantities. That is, the quantity is less, and these are the thalassemia syndromes. Or it may be qualitative, referred to as hemoglobinopathies, and this includes our sickle cell disorder. The third is hereditary persistence of fetal hemoglobin. Coming to history of sickle cell disease. Now, sickle cell disease was known much before 19th century, but was majorly known by the names of its symptoms. Dr. James Herrick, and this is a very interesting story. Dr. James Herrick is attributed to give the first description of sickle cell disease in 1910. But he was a cardiologist and he did not actually see this for the first time. He was not interested in looking into the peripheral blood smear of one of the Jamaican dental students who had come to him for his painful crisis. He asked his intern, Dr. Ernest Irons, to look into the peripheral blood smear, and Dr. Irons came up to him and told him that there are some abnormal looking cells which are of different shape than RBCs, and that is when James Herrick took interest in this case and looked into the peripheral blood film and gave his first description in 1910. After that, many developments occurred. So sickle cell anemia, the term was given by Vernon Mason. Hahn and Gillespie associated sickling with low pH and low oxygen tension. 1933, Diggs differentiated sickle cell trait from sickle cell disease. In 1948, the solubility test was given. But interestingly, In 1949, this Nobel laureate Dr. Linus Pauling gave the landmark finding by describing different electrophoretic patterns in sickle cell trait, sickle cell anemia, and normal individuals. Now, Dr. Linus Pauling, Nobel laureate, but he was not awarded Nobel for this discovery of his. Rather, he was awarded two Nobel prizes, one in chemistry and one for peace. And interestingly, he is the only Nobel laureate who has not shared his Nobel Prize. Both of his he has not shared. Well, uh, an year later, after Dr. Linus Pauling described his findings, there was discovery of the point mutation at sixth position, that is adenine is replaced by thymidine, or the amino acid glutamic acid is replaced by valine. Now, what are the different forms of sickle cell based on genotype? So, first is the homozygous sickle cell or the sickle cell anemia, which has the genotype HBSS. It will have two alleles, S alleles. The other is HBAS, that is sickle cell trait. So, in this, one allele would be S, one allele would be A. HBS beta thalassemia double heterozygous. In this, one allele would be S, the other would be either beta 0 or beta plus. HBSC double heterozygous, although this entity is not very common in our country but is more common in America. In India we can still see HBS D Punjab double heterozygous. So it would have, in HBSC it would have S and C allele. In HBSD Punjab it would be S with D Punjab allele. Inheritance pattern, it is autosomal recessive disease, and this is the classical uh, Mendelian genetics, in which if both the parents are sickle cell trait, that is if the genotype is AS and AS for both the parents, there are 25% chances that a normal baby will be born, that is will have no sickle gene. 50% chances or 50% babies would have a sickle cell trait or the genotype would be AS, while 25% of the offsprings would have sickle cell disease, that is that these would be homozygous for the SS. So what are the genetic alterations seen in sickle cell? Now, normal pheno person with normal genotype will have these six amino acids. If you see on this position, the glutamic acid is present on the sixth position. If one gene is normal, the other one is S, here you can find that the glutamic acid is replaced by valine, the adenine is replaced, thymidine is replaced by adenine. In the sickle cell anemia, that is person with both SS gene at the sixth position, both the amino acids would be valine. With a person with HBSC at sixth position, there would be valine in one gene while lysine on the another gene. If the person is HBS beta thal, one amino acid would be in one chain, the amino acid would be valine, while the other chain will be reduced quantitatively, or if it is the beta 0 gene, it would be totally absent. So there would be only one beta chain with two alpha chains. Coming to the distribution worldwide. So worldwide, if you can see, majorly the distribution is in the African continent, but there are cases present in the Northern America, South America, and if you see, entire India is seen to be affected by. So this comes in the moderate zone of almost 50 to 200 births per 100,000 births. And in that also in India, the majority of population is in the sickle cell belt of the central India, that is the tribal belts of Madhya Pradesh, Chhattisgarh, Orissa, etc. Now, why there is this type of geographic distribution? The main factors which are believed to play a major role in the increased frequencies of HBS include consanguinity. As I told that this is more common in the tribal belts, and consanguineous marriages are more common in these people, and therefore the sickle cell gene, as I told, it is the autosomal recessive. So if both the parents are trait, the gene is preserved in the family and it continues to go from one generation to another. The second is malaria hypothesis. I'll come to that in my next slides. And the third one is migration. Now, this is a hypothesis that many African people were brought to America as slaves, and that is where the sickle cell traveled from Africa to America. Coming to the malaria hypothesis, now if you see, this is the occurrence or the areas where the malaria is transmitted. Now compare this to the earlier picture that I had showed you, and you can see that the distribution is almost similar for malaria and sickle cell. Now why this happens is because depending on the genetic makeup, people have a different risk of dying when they are confronted by a parasitic organism. Even if a gene offering protection against that parasite were otherwise harmful. So it is postulated that the HBS is protected against the parasite, and therefore this gene continues in the areas where malaria is more prevalent. So although it provides advantage to SBS, its frequency would increase when the population was exposed to the parasite. The disadvantage with homozygous is that you would have homozygous conditions coexisting with the advantage of heterozygous. That is, if HBAS, that is sickle cell trait, is protected against the parasite because this gene is propagating in the future generations, there are chances of a homozygous condition, and this homozygosity is a disadvantage. That is, although they would be prevented by malaria, but they would have different kind of symptoms which are related to sickle cell. This is called as balanced polymorphism. Now, why this happens is, in a normal individual, if a person is affected with malaria parasite, this enters into the erythrocyte cycle of the malaria cycle, and there would be duplication and more number of copies of malaria parasite will be made. But in a heterozygous individual, that is in a AS, when the parasite enters the RBC, there is selective sickling of such cells. So such cells would undergo sickling and make the shape of sickle, and these would go and get phagocytized in the spleen. Therefore, this malaria parasite, the erythrocyte cycle stops there and then, and there is no duplication of this forms. That is how the protection is there for the heterozygous individual. Now, why does sickling occurs? Or if sickling occurs, what are the consequences of it? So, two most important result of sickling are hemolysis and vasoocclusion. But why does this RBC change its shape? So, in oxygenated state, this HBS is in a soluble form, and the biconcave uh, shape of RBC is maintained, which when we see in the peripheral smear, we see it as a spheroid shape with central pallor. On deoxygenation, what happens is the HBS starts forming polymers. That is, they are now no more in the soluble state, they come into the gel form. They start making polymers. If further deoxygenation occurs, this polymer length increases up to almost 14 HB molecules forming the polymer. And just imagine, this kind of a structure cannot fit into a biconcave shape, and therefore the shape changes to sickle. Now, at the earlier stage, if reoxygenation occurs, then further polymerization will not happen, and again the HBS would go into the soluble form, and you would get a biconcave shape of the RBCs. Also, on reoxygenation, the sickle cells will again go back to the biconcave shape. Now, on prolonged deoxygenation, the polymerized state is from soluble to polymerized, from fluid to gel state. On reoxygenation, again soluble to fluid state. With repeated cycles, that is the blood going from pulmonary, that is oxygenated, to capillary, that is deoxygenated state. Continuously this cycles goes on from fluid to gel, gel to fluid, but finally the membrane gets damaged and the sickle cells become irreversibly sickles. That means even if now the cells are oxygenated, they will not go back to the fluid state or soluble state. So at any point of time in a sickle cell anemia individual, there would be certain cells which are reversibly sickle cells and certain cells which are irreversibly sickle cells, and all these depends on certain factors which I'll come through in my next few slides. So what are the factors determining polymerization or sickling? So there are four key factors. One is oxygen tension. The second is amount of HbS or the HbS concentration. Third is the temperature. And fourth is presence of other variants of hemoglobin. Now this is an important slide, and because the entire management depends on how to prevent polymerization and sickling. So if these all factors are kept in control, the polymerization and sickling would be lesser. So only deoxygenated condition will produce sickling. What I mean to say is the oxyhemoglobin or the methemoglobin, all these would never form polymers and not form a sickle cell. So only deoxygenation would cause polymerization or sickling. So when the oxygen tension is low, the red cells tend to sickle. Also, with low oxygen tension, there are chances of acidosis and increased 2,3-DPG, and in these conditions also sickling occurs. HbS concentration has a positive correlation with sickling. More the HbS, more would be the sickling. Also, increased MCHC, that is cellular dehydration, increases HbS concentration, leading to more polymerization. Temperature has a dual effect. Although cooling decreases polymerization, that is sickling. So cooler temperature should ideally decrease polymerization of sickling, but the temperature required for this phenomenon are subphysiologic. That is, these factor does not prevent sickling in vivo. These can be done experimentally but does not happen actually in the human body. However, decreased temperature causes vasoconstriction, and this is postulated to increase the severity of sickling. That is, although the lower temperatures decrease polymerization, but because of vasoconstriction, the severity of sickling increases. Presence of other variants of hemoglobin. So both HbA and HbF have an inhibitory effect on polymerization. So more HbF concentration or more HbA concentration, lesser would be the polymerization or lesser would be the sickling. In Bedouin Arabs of Saudi Arabia and tribes of central India, sickle cell anemia is associated with significant elevation of HbF, and therefore they have a less severe disease. On the other hand, the African population, the HbF concentrations are low, and therefore they would have a more severe disease. So what happens because of sickling is vasoocclusion. Why does this happen? This happens because of two phenomena. One is adhesion. Sickle cells show an abnormally increased adhesion 2 to 10 times to the endothelial surfaces. This adhesion is moreover promoted during inflammatory conditions or infectious condition because of leukocyte activation and release of cytokines. So infections would increase the chances of vasoocclusion. On the other hand, due to hemolysis, heme is released, which decreases the nitric oxide concentration, leading to increased addition molecules, vascular tone alteration, and slowing of the blood flow. Combination of these two mechanisms along with interplay between various cellular components is responsible for vasoocclusion. Coming on to clinical features. Now clinical features can be divided into two, that is acute events, which are also called as crisis, and the chronic, which are complications or organ damage. The symptoms are not seen in infants. Now why does this happen? Because as I told, up to 4 to 6 months of age you would have presence of HbF, and presence of HbF inhibits polymerization. So infants would not show symptoms. Mild hemolytic anemia and splenomegaly are the earliest symptoms. Here again, in earlier phase, you would find splenomegaly, but in the later stages, the spleen becomes shrinked and small. Vasoocclusive symptoms starts appearing after around 10 months of the age. Some have severe disease with early mortality, as I told earlier, while few may live a near normal life with lesser complication. Also, as I said, there are two important phenomena, vasoocclusiveness and hemolytic anemia. So, vasoocclusive symptoms are more common than hemolytic anemia. Coming to acute events or crisis, these are recurring attacks of pain, that is the vasoocclusive crisis, are the recurring attacks of pain involving skeleton, chest, abdomen, or all the three, usually recurrent and catastrophic, sudden in onset, and directly attributable to obstruction of the microcirculation, often preceded by inflammation. As I said, inflammatory markers increase the adhesion and activation of endothelial cells, leading to more vasoocclusion. The other precipitating factors are cold, pregnancy, and physical exertion. Vasoocclusive crisis, the most common is hand-foot syndrome or the dactylitis. It is the most common symptom presenting symptom in childhood. As the age grows, the painful crisis reaches to other larger bones and joint, and if there is infarction in the mesenteric vessels, the abdominal pain crisis happens. Stroke is an important acute event and is responsible for most of the mortality and morbidity in sickle cell anemia. It is abrupt onset of hemiparesis, aphasia, seizures, sensory deficits, and altered consciousness. Acute chest syndrome may be seen in children as well as in adults. In children, it is most commonly due to infection, while in adults, it is most commonly due to infarction. Priapism is a very important symptom that is shown by children due to vasoocclusive crisis. In this, there is a prolonged painful erection, and this is commonly seen in young boys, and they present with priapism. The other acute event or the crisis is the hematologic crisis, sudden exaggeration of anemia, usually unrelated to vasoocclusive crisis. These may be severe enough to cause heart failure and death within hours. Now, hematological crises are again divided into four, that is aplastic crisis. Now, these aplastic crises are attributed to parvovirus B19 infection. These are self-limiting and usually are for 1 to 2 weeks they would present as aplastic crisis, pancytopenia, and then as I said, these are self-limiting and therefore the bone marrow starts producing cells again. The next is splenic sequestration, in which the pooling of blood into spleen increases and therefore it causes peripheral pancytopenia. You can have megaloblastic crisis, as this is a hemolytic anemia. The demand for folate increases in the bone marrow and therefore it is possible that folate deficiency occurs and patient presents with megaloblastic crisis. There can be hyperhemolytic crisis, that is, although it is a hemolytic anemia, sometimes in this crisis the rate of hemolysis increases and the RBC destruction increases, presenting as hyperhemolytic crisis. Infections may be the presenting manifestation in early childhood. Previously, this was the most common cause of death in sickle cell anemia. Nowadays, with better treatment modalities and better hygienic conditions, infections are seen lesser, or rather they are treated properly, and patients do not usually die because of infections. The most common or fatal infection is of Streptococcus pneumoniae, leading to fatal sepsis or fatal meningitis. E. coli is also common in older age group, causing UTI. Osteomyelitis usually in normal individuals is caused by Staphylococcus, but in sickle cell anemia it is seen that Salmonella is more responsible for causing osteomyelitis. Parvovirus B19 I have already emphasized in the aplastic hematologic crisis. Now here I'll introduce to two terms. One is functional splenectomy and one is autosplenectomy. Now sickle cell anemia, because of repeated infarction in spleen, repeated infarction and fibrosis leads to a smaller spleen, and therefore unlike other hemolytic anemias in which you would find huge splenomegaly, in this you find very small fibrospleen, and that is autosplenectomy. Moreover, there is functional splenectomy, that is spleen stops functioning, and that is one of the most important cause for more propensity to infections in these cases. The chronic features are chronic organ damage, growth and development, physical and sexual both are impaired. In skeletal system, you can have osteonecrosis, avascular necrosis, lung diseases with fibrosis are common. Renal concentrating function in renal medulla is impaired, and this is very common and is the earliest sign of kidney damage, and this is again because in the medulla the oxygen tension is low, leading to impairment of the concentrating function. Person may present with proteinuria, hematuria, acute renal failure, nephrotic syndrome, hepatomegaly, viral hepatitis, chronic skin ulcers, retinopathy. Pregnancy is a special condition, and in sickle cell also it becomes special because here the chances of spontaneous abortions, IUGR and stillbirths increases. Again, the pathogenesis is vaso-occlusion and hemolysis. To summarize, each and every organ is almost involved because of sickle cell anemia. There can be acute complications which are known as crisis, and there can be chronic complications that are chronic organ damages. Coming to approach to diagnosis, now here, as we all know, the first most important test is history and examination, and again in sickle cell this is true. Clinical details, ethnicity, painful crisis, splenomegaly at early age, symptoms and signs of hemolysis, etc. must be carefully documented, and with high degree of suspicion, complete blood counts and peripheral smear examination must be asked for. Also, the test to establish hemolysis such as reticulocyte count, LDH levels, bilirubin, etc. must be ordered. In case there is a suspicion of sickle cell anemia or sickle cells are seen on peripheral blood smear examination, you can go either for sickling or solubility test or HPLC and electrophoresis. So now this is the usual approach to diagnosis of sickle cell anemia which is followed in our country. For clinical purposes, an adequate presumptive identification requires combination of at least two techniques of HB variants, clinical correlation, ethnicity of patient is very important, and interpretation of CBC and peripheral film examination. All this in combination leads to the diagnosis of sickle cell disease. Complete blood counts are important. Hemoglobin, hematocrit, red cell counts are usually low in SCA while would be normal in SCT. Neutrophilia and thrombocytosis can be present. In fact, chronic neutrophilia is a poor prognostic indicator. MCV is usually within normal range, but if there is a double heterozygous with beta thalassemia, then lower MCVs are seen. RDW increased. Reticulocyte count is variable but usually increased with a high reticulocyte index. Peripheral smear examination is one of the most important examination, and although we all know the importance of automated analyzers for CBC, this is one disease which is rarely picked up by these automated analyzers. There have been studies in which graphs and scattergrams are used to uh, create a suspicion whether sickle cells are present or not, but peripheral smear examination in this condition become very important. You cannot get it from the automated cell counters. What we see here are the holly leaf cells or the sickle cells, and these cells are characteristically pointed at both the ends. Along with these, you can find nucleated RBCs and few polychromatic cells. Coming on to sickling test, we use 2% sodium metabisulfite as the reducing agent, and we mix it with the peripheral blood, and we keep it on a glass slide and cover it with a cover slip and seal it with petroleum jelly. Basically, what we want is we want that RBC do not get enough oxygen, and when the RBCs are deoxygenated, they convert themselves into sickle cells. We observe this under the microscope periodically up to 24 hours, and if we see such sickle cells, the sickling test is reported as positive. In solubility tests, the RBCs are lysed with strong hemolytic agent, and the HBS is reduced by sodium thionate in presence of concentrated phosphate buffer or saponin. With this reducing agent and strong buffers, the HBase polymerizes and it precipitates. Hemoglobin electrophoresis in alkaline condition is a very important test in diagnosis of hemoglobinopathies. Basically, in this, under electric current, the hemolyzed, that is the lysed RBC only hemoglobin, is applied on this acromide gel card, and in presence of electric current, the hemoglobin, depending on the charge present on them, will move in on this card, and we can read it according to their positions. So for example, in this, this may be a bit faint, but this is the actual electrophoresis graph which I had during my thesis. So I had a thesis on sickle cell. So this is the graph from the from one of the graphs of my patients, various patients. Now, if you see here, this patient A, this patient D, and this patient H have only one band, and this band corresponds to HbA. If you see B, C, F, and G, you can see there is again only one band, or you can see a minor second band. So the top band corresponds to HbS, while the bottom band corresponds to the HbF. If you see this case, the E1, there are two bands, and one corresponds to HbA and one corresponds to HbS. So the individuals A, D, and H are normal AA individuals. Individuals B, C, F, and G, which have sickle and HbF, are sickle cell anemia cases, while this individual E, which has A band and a S band, is a sickle cell trait, that is AS. Now, if this was fit, this is the typical book picture. So from cathode to anode, the hemoglobins will travel. The first step would be A2, E, O, and C. The second would be S, D, G, and Lepore, then F, then A, so on and so forth. Now, as you can see here, that almost four types of hemoglobin are corresponding to one uh, position. So to differentiate between these four, we have to do a hemoglobin electrophoresis in acidic medium. Nowadays, the most common test has become, and the favorite test has become, the hemoglobin high performance liquid chromatography, or HPLC. Now, in Pursue, we earlier had a lecture on HPLC interpretation. You must go and look into that. I'll just show here two examples. Again, we have to remember that the band positions here are not similar to the electrophoresis. So these are different, and these are based on the retention times of various hemoglobins. So in this case, you can see that there is HbF present and HbS present and a minor window of HbA2. This is a case of sickle cell anemia. And in this case, if you can see that HbF is a minor window, but the HbA is a big peak, and similarly HbS is a big peak. So you have HbA and HbS. This is a case of sickle cell trait. The other tests are isoelectric focusing. So isoelectric focusing is similar to electrophoresis, but this is based on separating HB according to their isoelectric points. This test has a higher resolution but is expensive and rarely done for routine diagnosis. However, this is the gold standard test for newborn screening. The electrophoresis is nowadays done on the capillary mode, that is capillary electrophoresis, and this is advantages as this requires lesser quantities of the blood. It is recommended that on a positive electrophoresis or a positive HPLC result, each case must undergo genetic testing, but this is not the recommendation for India. Although genetic testing becomes very important in doubtful cases, in parental screening, and these are important for precise detection of various types of sickle cell diseases. These may be PCR based techniques, this may be RFLP or next generation sequencing. In the most important use of genetic testing is in the prenatal diagnosis. There are newer innovative methods such as artificial intelligence detecting the sickle cells or the flow cytometric analysis of HBS, the physical properties to differentiate sickle cells, lateral flow immunoassay, paper-based solubility testing, pyrosequencing, etc. But all of these are in research model. These are all startups coming up with their ideas and not into regular diagnosis as yet. To summarize the laboratory feature, sickle cell trait genotype AS would have all normal RBC parameters. The solubility test will be positive in all the sickle cell diseases. The electrophoresis or HPLC pattern in sickle cell trait, as I have already told, the HbA would be 50 to 70%, HbS 30 to 40%. There would be no clinical findings. The patient would be asymptomatic, so-called carriers, which would transmit the disease from one generation to another. In sickle cell disease, that is homozygous SS, usually the anemia is present 6 to 9 grams per deciliter. Hemoglobin, these are normocytic with presence of sickle cells, NRBCs and polychromasia. HbS is 50 to 90%, HbF is 10 to 40%, and the major clinical findings are vaso-occlusive crisis, hemolytic crisis, chronic anemia, chronic organ damage. In the double heterozygous sickle cell beta thalassemia, the genotype is S beta plus. Now this is a beta plus thalassemia. That means the quantity of beta chain would be lesser. These would present with an anemia of 8 to 12 gram per deciliter. Microcytic hypochromic, sickle cells might be present, might not be present. NRBCs are present, target cells might be present, might not be present. In this, the HbS is usually more than 50%, HbA2 is usually more than 3.5%, and HbF is usually more than 20%. Clinically, these are milder but can get aggravated in hypoxic conditions. The other variant is sickle cell beta 0 thalassemia. In this, the beta chain is absolutely absent. This would be severe anemic or moderate degree of anemia, 6 to 9 gram per deciliter. Microcytic hypochromic sickle target, both cells would be present and RBCs would be present. In this, HbS would be more than 75%, A2 more than 3.5%, but the HbF would be less than 20%. These show severe clinical symptoms and signs similar to homozygous sickle cell disease, that is vaso-occlusive crisis, hemolytic crisis, chronic anemia, and chronic organ damage. HBSC, as I told, not very much common in our country. Again, present with microcytic cells. HBS and HBC both are present in equal proportions. These are usually milder than the homozygous sickle cells, but presents as chronic hemolytic anemias. Coming to management. Now, management, as I told you, is based on the pathogenesis, that is increase the oxygen tension, that is give oxygenation, give supportive hydration, try to increase HbF, prevent infections, reduce the HbS concentration. Pain is managed with opioids and NSAIDs. Crisis prevention is very important. Early detection and treatment of infections is important. Avoid exposure to cold, stress, hypoxia and dehydration. These patients are usually vaccinated for pneumococcal vaccine, influenza vaccine and penicillin prophylaxis is indicated during early childhood. As told, pregnancy special condition, close monitoring for vaso-occlusive crisis is very important. Iron and folate supplements are important. Transfusion, there are criteria for transfusion. Acute chest syndromes and strokes are managed in hospitals according to symptoms along with exchange transfusions, hydrations and oxygenation. Priapism, early detection is very important because any delay would cause impotency. These are managed by analgesics, hydration and sedations. Priapism usually is self-limited and in that sedated state the priapism gets released and the patient is relieved. Chronic organ damages are managed by organ specialist accordingly. Blood transfusion, the goal is to increase oxygen carrying capacity of blood and reduce the HbS component to 25 to 30%. There can be simple transfusion or exchange transfusions. Exchange transfusions are indicated in severe acute chest syndrome where the oxygen saturation are less than 90%, multi-organ failures, acute ischemic strokes, twin pregnancy, etc. While simple transfusions are given in splenic sequestration. Now here one thing is important, that the anemia should never be corrected completely because the blood is pooled into the spleen during splenic sequestration, and once this is relieved all those pooled blood would come into peripheral circulation again, and if the anemia is treated completely there are chances of overload. Simple transfusions are given in acute anemia or hemolytic crisis, and when in pregnant conditions when hemoglobin is less than 7 or there is a drop of more than 2 gram per deciliter from the baseline. The management with drugs came very late after the discovery of sickle cell. It was in the in the late 80s and 90s that hydroxyurea was approved by FDA. Hydroxyurea works on a simple concept of increasing the concentration of HbF. And as I have already told, more the HbF, lesser the chances of polymerization and sickling. Thus, the patient is relieved by hydroxyurea. Now, indications are usually the poor prognostic markers, that is more than 3 crisis episodes, history of acute chest syndrome, chronic neutrophilia, pain or anemia affecting day-to-day activity. It is contraindicated in pregnancy and breastfeeding. Voxelotor that inhibits HbS polymerization, crizanlizumab, the monoclonal antibody which inhibits p-selectin, are other FDA approved drugs which are used in sickle cell anemia management. Hematopoietic stem cell transplant is the only curative option for sickle cell anemia patients, but unfortunately there is no chance of having a matched sibling or very less chances of having a matched sibling. So most of the times these patients have to go for unmatched blood stem cell transfusions. The National Sickle Cell Disease Control Program was given in 2016 with the mission to improve care of all SCD patients for their better future and to lower the prevalence of the disease through multi-phased coordinated approach towards screening and awareness strategy. And the vision is to eliminate sickle cell disease in India before 2047. How does this happen? There are three important pillars to the program: health promotion, that is awareness generation, and marital genetic councils. This is one of the most important thing that is being done. Second is prevention, that is universal screening and early detection, and holistic management, that is managing at all the levels, that is primary, secondary and tertiary levels of healthcare management. Well, I would conclude here by saying that sickle cell disease comprises of various hemoglobinopathies with presence of HbS, sickle cell anemia being the most common. A combination of at least two techniques of HB variant study along with correlation with ethnicity, peripheral blood findings and clinical symptoms is required for diagnosis. Early detection and immediate management is the key to reduce severity and mortality in sickle cell diseases. Prevention is better than cure. Prevention and control are cost effective, realistic and are beneficial. ISHBT along with ICMR has given national guidelines in management and control of sickle cell disease. There are wonderful recommendations in this guidelines available on the internet, and you can go through it. June 19 is celebrated as World Sickle Cell Day, which was started in 2010, celebrating the 100 years of discovery of sickle cell disease. So June 19 this year, again we'll have a World Sickle Cell Day. This is the college where I am currently assistant professor, R.D.Gardi Medical College in Ujjain, which has the tribal population just nearby, which is affected with sickle cell anemia. And therefore, I have been into sickle cell. In fact, my thesis was on sickle cell diseases, and I actually traveled to this tribal population and got many cases of sickle cell disease. Thank you very much.